Hello, everyone. So we're going to just get started. I will start by introducing Dr. Helen Verdeli. Dr. Helen Verdeli is an associate professor of clinical psychology at Teachers College, Columbia University, and is the founder and director of the Teachers College Global Mental Health Lab. She is a scientific advisory council member of the American Foundation of Suicide Prevention and the scientific advisory board of Depression and Bipolar Support Alliance. She collaborated internationally with academic groups, ministries of health, local NGOs, and international agencies to alleviate the suffering of adults in Uganda, women in Colombia, distressed patients in primary care in India and Haiti, and refugees from Syria and Rohingya.
Let me share my screen so I can. Give me 1 second. Great. Can you see my screen well?
We can see.
Yeah, you can see.
Yeah, we can see it.
Okay, good. So, so I do global mental health work. I'm a clinical psychologist by training, and my work focuses on adapting and testing psychotherapy for depression, anxiety, for low-income regions around the world, including many of them in the United States. So I'm the director of the Global Mental Health Lab, and these are some of the sites that we have been working. In Colombia, we have worked with IDPs, internally displaced persons, in an open trial with psychotherapy. My focus these days is a lot on working with displaced people. So we have been working the last 6 years in Lebanon with Syrian refugees, and I'll discuss this work with you and lessons learned. And I have this close collaboration with the United Nations High Commission for Refugees. So we work in Bangladesh, that's the other area that I'll focus today, with Rohingya refugees, people who underwent a genocide recently and are in a camp of 900,000 people. That's where we worked. Interestingly, for, in addition to other sites we have, recently, we started working in Peru with Venezuelan refugees, and I was telling the other days, just before we started, that we are training Venezuelan psychologists to do therapy with refugees with some good uptake, initial uptake. We haven't finished the work there yet. So the treatment that I'm going to discuss with you is called group IPT, interpersonal psychotherapy. It's one of the two evidence-based therapies for depression and other mood disorders, and more recently for post-traumatic stress disorder. And the World Health Organization, recognizing, its effectiveness for use in low resource settings, asked us to turn over the copyrights to them. So we did, with Dr. Myrna Weisman, who is the founder of IPT. And it has been translated in a number of languages, including Swahili very recently, I'm told. We have a small also manual for use of IPT, we call it IPC, interpersonal counseling, for primary care, and is disseminated also in the WHO, in the MENA region. So let me tell you a little bit about this treatment. It was developed in the 70s by my mentor, Myrna Weisman, and Jerry Clerman and colleagues. It's a time-limited psychotherapy, and it really focuses on improving symptoms and interpersonal functioning. Um, it has a basic principle that depressive episodes are triggered by interpersonal difficulties in some of the some problem areas, crisis and difficulties, basically four problem areas. So you see, we don't talk about causes of depression. The causes could be, you know, genetic, epigenetic, uh, um, early experiences. We talk about triggers of episodes. So grief is a powerful one, ubiquitous around the world. Death of a person that plays an important role in our lives. Interpersonal disputes, disagreements, overt disagreements where people fight, but also covert when they don't fight openly, but there is a lot of resentment and coldness. Um, Role transitions, life changes, the obvious ones, the negative ones and stressful ones that have to do with changes in health status, um, ourselves and loved ones, losing jobs, losses, right, divorces, um, but also some positive ones, strangely, can trigger depression, like promotions, for example, or having a baby, or getting something that you really have fought for a long time. So there is, because every time we make a move forward, we always lose something important. And the final one is loneliness and social isolation. So the understanding is that by working in this, in these areas with a person and what trigger the depression and help them build skills to manage it, better, we can help the person recover. Thank you. So let me tell you a little bit about the funding for our Lebanon projects. We started working with them in 2016 by the international. We got a small grant by the IMC, and then there was a phase 2 because of the initial success of IPT. We got a bigger grant from Canada, the federal government, and we did a training of trainers, and then we have an implementation study later on in primary care. So you may know a little bit about Lebanon. It's a middle-income country, small country, 4 million people, and they have now close to 2 million refugees, which, it's a tremendous burden for the people. So the Ministry of Public Health there approached me, and I have to tell you, one of the reasons that I was so happy to participate in this conference, in addition to the fact that my friend Christina Hoven asked me, is that I see, the participation and the interest and the involvement of the ministry and very, key agencies, right, in this. Without it, I don't think that any of these projects can really thrive and be sustainable. So this is what happened in Lebanon. The Ministry of Public Health asked me, because IPT, has been supported by multiple randomized control trials in a number of regions around the world. It's part now of the World Health Organization Mental Health Gap Intervention Guide, and recommended and disseminated. Has been tested and used not just by mental health professionals, but also non-specialists. And this is something that I do a lot around the world, working with non-mental health professionals, especially in primary care. And I have to tell you, some of my very good therapists around the world are not mental health professionals, but to do this safely, they need to work with, mental health professionals who have the oversight um, and see complex cases. And the ministry also felt that the interpersonal focus of IPT made a lot of sense and was relevant to the experiences of Syrian refugees, life changes, and a lot of deaths and horrific deaths, disputes with a host community, with other refugees, and a lot of loneliness. And in Lebanon, we had many analytic colleagues, psychoanalytic therapists, and this emphasis of attachment appealed to them. So this is, the models of implementation we have developed in our first work in Uganda, and have been using since, and other colleagues have used and elaborated on this apprenticeship model of training of trainers. It's a 3-tier model where we train, the master trainer. We are the master trainers that train a local trainee supervisor, who in turn trains the providers. It's a cascade model, but we have developed very specific, predetermined indicators of competency for each level. So we also try to, target, and track different key factors on policy, right? Policy changes, provider, patient, local systems, and accountability mechanisms. So this is what I was talking to you about. In 2015, my colleague and now close friend Rabil Shamai from the mental health unit of the ministry developed this 5-year initially mental health strategy, and now they extended it to 2030. And it was a human rights-based approach. They said that everyone who lives in Lebanon, whether they are refugees, displaced persons, or Lebanese, they should enjoy great mental health, excellent, evidence-based, community-based mental health, instead of creating yet another vertical system for refugees and having the host population not benefiting from this. They developed something for everybody, and comprehensive, integrated, and responsive mental health services. So we worked with, key actors in implementation. I have to say, it was the first time where I went and sat at the same table from the very beginning of the project with the ministry, with academic colleagues, with NGOs, with other clinicians and hospital administrators. So from the beginning, we focused on targeting key actors in the dissemination. And recruit therapists for this. It was a competency-based training, so we provide skills and ongoing support, which we continue, by the way. We have a continuing education model. When I talk about training, I don't mean a hit and run, workshop. People don't change behaviors. These workshops are good. They make people quite enthusiastic. But if there is no, continuity, and if there is no supervision, it fizzles out. Also, people need to make, advancements, right? And they have to. So the continuing education model is that the former providers became supervisors, right? And we are now having the master trainers in Lebanon, right? So we are phasing out because the local colleagues are taking over, and they are doing an amazing job. And this is also brain drain reduction strategy, because people have incentives to stay here, to stay in the And we are developing also learning collaboratives. We are going to launch one digitally based collaborative. So this is how we started, and this is our next one. These are the milestones that I mentioned before, the competency milestones. People have to attend the training workshop, they have to pass a knowledge test, weekly supervision on 3 cases, they have to achieve like some predetermined competency levels on adherence lists. Same thing for IPT training supervisors. They have to meet competency levels. We co-train with them and co-supervise as we phase out. Just to tell you a little bit about our findings, in the majority, they are women, our trainees, Lebanese, and these are the providers, as you see, and here are the trainee supervisors. Mainly, not exclusively, clinical psychologists with some psychiatrists and social workers and nurses. Mainly, the majority employed in NGOs and hospitals, and master's degree in mental health. In the majority, they were psychodynamic, some eclectic. And this is how, so in the initial training, we started with 18 participants, and we managed to train 15 who met all the criteria that we had predetermined. 10 of them applied to become supervisors. 9 of them finished their competencies successfully. And then they co-supervised, right, with us, the IPT providers who finished now their trainings themselves, and 25 of them graduated. Let me tell you about the patients, because if this doesn't result in patient improvement, this exercise is totally futile. So these are the patients, in their majority Syrian refugees and very poor Lebanese or Palestinian refugees there, who have also been suffering quite a bit. Remember, Lebanon is, since the influx of the refugees, was plagued by, you know, the financial problems, some recent, you know, escalations in government, the blast in Beirut, and COVID, of course, right? So they didn't have a break. So here are our results: the anxiety, depression, and PTSD. We used PHQ-9, which has been, all these have been validated in Lebanon, GAD-7, which is for generalized anxiety disorders, and PCLC, which is a scale for PTSD, with very good results, I have to say, very heartening results. We are going to apply for a randomized controlled trial now, very soon. And who does for this shows, you know, improvement in functioning. Now, the other population that I wanted to discuss with you is also about a refugee population, but quite different, in a different area of the world, with a very different set of challenges there. We are still struggling with them, I have to tell you. So this is a study funded by UNHCR. It's an adoption study of IPT in the context of forcibly displaced Myanmar nationals, or Rohingya Russians in Bangladesh, in this refugee camp of 900,000 people. It's a mega camp, Kutapalung, with different sections, plagued by flooding in Cox's Bazar. And this is our team. Now, so far, we are in the 2/3 of, the um, way. Um, we manage out of 17 active providers, 12 are the ones that are still active. And we have 5 who dropped out due to a number of organizational and situational challenges. Some of them relocated or changed positions within the organization, others for personal reasons and health reasons had to leave. We had mainly 4 different organizations. So far, we had 22 cases that treated to target. So this is a strategy, I have to tell you, that we also used in Lebanon. We didn't have the more cookie cutter, approach that, we and others had used in the past, which is like 12 sessions or 16 sessions. We had, some people need 7 sessions to feel better and others need 20, right? So we had some decision-making rules along the way, but it was a measurement-based and treatment to target approach. So when we met predetermined criteria of improvement, like, um, remission or response. Response is 50% from the original score, PHQ score, and remission below a cutoff, which with PHQ is 4 and below. We now have 13 active cases being treated, and we had high levels of relocation to other camps and dropouts, mainly because of relocation. One of the reasons was a huge fire. I don't know if you're aware of it. On top of, so the refugees, these refugees underwent a genocide, an incredibly bloody genocide. They had to cross the river. They saw some horrific and suffered horrific losses. They left their land, crossed the river, and reached Bangladesh. And since then, they lost again many times what they had and built in the camp because of flooding, which is a perennial problem there, and this terrible fire that happened 6 months ago, and COVID now. So actually, for this talk, I went over and looked our results so far to see how we are doing. It was a good, and I was quite happy to see that, we have, quite good results. In PHQ-9, GAD, we don't use the PCL, we use the PTSD-8. It's briefer and was translated in Bangla and Rohingya. So these are the results. So we saw significant drops in symptoms. Now, this is what I was talking before. We usually do these treatments, at least in high-income areas around the world, where, there is, the person was exposed to the trauma, but went to a setting when they are safer, no longer exposed, right? They're safe, and they do either exposure or other non-exposure treatments for, symptoms, whatever the major symptoms are. Over there, the people are constantly exposed to, ongoing problems with food, the fire, the floods, and violence, a lot of violence in the camps. Women with children, if they don't have a man there to protect them, are incredibly vulnerable, incredibly vulnerable. A lot of gender-based violence, lockdowns and movement restrictions. So people keep being exposed, ongoing exposure. Um, the training, the challenges in the training are that, many times we have connectivity problems. So it's endless hours, these supervisions are like 2.5, 3 hours long sometimes over the internet. I have to say I'm very touched by the dedication of our colleagues in Bangladesh and the inspiration they give us. And, we have adapted a lot, both for Lebanon and Bangladesh, the treatment. And this is what I want to discuss with you a little bit. We pay attention. The basic structure of IPT is not different, but we go not for linguistic equivalence, but for conceptual equivalence. So some of the terms, when literally translated, don't, of course, mean much, but we try to identify if the concepts make sense. IPT has a certain advantage in the sense that, first of all, people find it quite non-stigmatizing. Like, the point of departure of this treatment is that it's not that something is wrong with the way you think or you feel or you behave, but what happened to you. We focus on things that happen in their lives that really triggered, this distress. We really focus on the local idioms of distress. In Iktiab, Syrian refugees were calling Iktiab, depression, but with a lot of anxiety. And every time they say Iktiab, they point out to their heaviness in the chest, in the heart. Interestingly, the Rohingya refugees talk about bad heart. That's the equivalent of depression with some anxiety that they feel is mental health need priority there. This is something that it was found out in qualitative studies that we have done. So, and then we try to, with open-ended questions, we try to understand whether what the local trainees and communities consider as triggers of a child, how they map onto the problem areas. And because of, the roots of IPT on attachment and the importance of interpersonal relationships, it makes a lot of sense to people around the world, to really focus on, death, right? Life changes, and loneliness and disputes. So, interestingly, loneliness is the problem area that in some areas of the world we found that people don't necessarily consider it as a trigger of depression. And these are areas where mainly, it's work with non-displaced persons. With displaced persons, we found out that loneliness is also a key problem area for them, because they lost important ties, the severance of, relationships, and also the suspicion about some political, issues that continue in the camps, make them feel cut off and lonely. The other big issue we have in Lebanon, but in Bangladesh a lot, was domestic violence and gender-based violence. That was really very high. And part of this work, involves the mobilization of protection systems. So I would like to actually stop sharing right now, because I'd like to have the chance to take your questions and discuss your thoughts about this, if you have any. I see some colleagues who, yeah, or you can unmute yourselves and ask the question, which is fine, actually. See some colleagues from cardiology unit. Okay. Please unmute and join the discussion. Yeah.
At this moment, we don't have any in-person questions, but anyone who would like to ask a question, please join in online.
If not, I can talk a little bit about our experience with the working with Venezuelan refugees. When Christina, Dr. Hoven, asked me to present on IPT, she thought that working, the work that we have done with Muslim populations was also of interest to, to our colleagues here, you all in Guyana, because there is I was reading, at least 10% of the population here is Muslim. So, and for us, it was important to see that it works with populations, of different religion, faith, and different ethnicities so far. But let me tell you a little bit about the work now in Peru with Venezuelan refugees. So I'll use the last 5 minutes. So the partners there on the ground are HIAS, which is a big NGO that works with refugees, not just on mental health, also other, needs. So, Natalie, oh my God, from the internship in 2002, thank you. I just got a former trainee of mine who is here. I just see her. So good to see you, Natalie. So there, what we had is some organizations with Venezuelan refugees who are psychologists, some social workers, and a psychiatrist or two, who wanted to be trained. Interestingly enough, we have a lot of interest in IPT, and we trained lawyers who do international work and are advocates, lawyer advocates who came to our training, and they really liked, the work, because they see a lot of mental health issues with the clients. And now We have now developed with Myrna Weisman and Kathy Clogarty this 3-session IPT, IPC3, we call it. 3 session, not to cure people within 3 sessions, of course, but as an engagement strategy, because we realized that by, some people actually, for some people, mobilization of resources, asking them this simple question: tell me what's happening in your life. What happened to you that made you so distressed? Giving them hope, and telling them not to, that distress and depression are common. They're also very impairing. Other people call them, lazy or cold or indifferent. But that this is depression, and giving them hope that we have good treatments for that, and helping them clarify, the disputes and transitions and losses and loneliness that contribute, and find some very, very simple ways to help them get mobilized, to find options and mobilize people. So for some people, this is enough. And then others need more than that. So around the world now, the non-mental health professionals are interested in using this 3-session IPC, so that at the end of that, they can also make the referral for those who need it. And our refugee, Peruvian and mainly Venezuelan refugee colleagues are seeing now the clients who, are struggling a lot with survival issues, basically quite a bit like the Rohingya refugees. Many of them are plagued with a lot of guilt and pain about, relatives in Venezuela, you know, and send them the meager, amount of money. And sometimes there's a lot of resentment for that, because the relatives who are also drowning and in Venezuela, and they're full of anguish, they're trying to survive, they're asking more and more. But also the people in Peru are struggling and live under very difficult circumstances. So there the very preliminary results there, because we started with Peru 7 months ago, are they're very heartening. What is incredibly satisfying for me is and gratifying is to see how dedicated our colleagues are, and how the what they bring from their experiences, personal experiences, ingenuity in using IPT, flexibly. So I have to finish here because we are, I think, out of time. And I hope to continue the discussion with some of you very soon. Take good care. I see my friend Francine, who just